Good evening, ladies and gentlemen. I am Indrani Malpani, Chairman and Managing Trustee, V Citizens Action Network. A warm welcome to all of you to our Social Sanchar with Dr. Abhishek Mangeshikar, gynecological surgeon and endometriosis specialist. Dr. Mangeshikar is also the director of Indian Center for Endometriosis and consultant with, amongst other hospitals, Jaslok, Bridge Candy, ACI, Kambala Hill, etc. This evening, we are conducting the Social Sanchar on an issue for which there is so much of ignorance of the disease and condition, even though it is so common. All girls and women of all ages, and it can affect all organs, not just the reproductive ones, and that is endometriosis. I ask this question, why should women suffer because of ignorance? So ignorance is something that we need to eradicate. As a community, we need to speak up about endometriosis. We need to spread awareness because the numbers are huge and we know not much about it at all. So this session is not just for women at all, and it is a must for men as well, because our sisters, daughters, mothers, as relationships in so many spheres, it's all connected, and we really, all of us, need to know about this common condition or disease. Before we begin the full session, I would like to tell you a little bit about ourselves, that is V Citizen Action Network. VCAN, the acronym, is a registered public trust, and our overarching objective is to create linkages between citizens and government authorities, and in a spirit of partnership with several government departments and authorities. Our focus areas include health, pollution, particularly air pollution, road safety, fire safety, cybersecurity, waste management, electoral processes, among others. We are a non-political, non-profit trust, and all donations are exempt under the Income Tax Act, Section 80G. Many of you have been following our portal, our work, and have also been visiting the portal quite frequently. Many of you have been participating in our social sanchars, and for which gives us encouragement to take our work forward, because that's our prime motivation. With the ongoing COVID situation, we started our new version of the Social Sanchar, which is fully digital, and we started a new series on health and well-being, featuring leading doctors and healthcare professionals as our speakers. We hope this new series will receive the same positive feedback that our regular social sanchars have received, and though the regular sanchars will also continue once the public gatherings are fully allowed. I would now like to particularly thank our support partner for this social sanchar, the Indian Center for Endometriosis, in short, the acronym ICE. And this organization will also, has already, in fact, associated with us to take our awareness campaigns forward post the session. Our warm thanks are due to our implementing partner, CACR, Citizens Association for Child Rights. I'm particularly delighted to have the students, the student council, and the various clubs of our college partner, Jai Hind College, and also the support of many colleges through our college partner. I thank Team Technolegion for powering this version of our social sanchar and always being vigilant to keep our web portal going. I also thank Mr. Sumitullah, our consultant for social media. I thank our friends in the media and for all of you for joining us this evening. May I now request my fellow trustee, Mr. V. Ranganathan, our former municipal commissioner and has also led the state of Maharashtra as the chief secretary, to introduce our guest speaker, Dr. Abhishek Mangeshekar. Mr. Ranganathan, would you please introduce our guest speaker?
Good evening. A warm welcome to Dr. Abhishek Mangeshekar, the lead speaker today on this session on endometriosis. Is the most common disease worldwide, which we have not heard of. Dr. Mangeshekar is an MS in obstetrics and gynecology and has also done fellowship in minimally invasive gynec surgery and diploma in pelvic endoscopy. He is the founder director of Indian Center for Endometriosis and presently is a consultant to Kambala Hill, Bleach Candy, Saifi and Jaslok hospitals. We couldn't have got a person better than Dr. Mangeshekar to speak on a common but neglected ailment, endometriosis. We look forward to an enlightening presentation from Dr. Mangeshekar on the preventive measures and treatment for this ailment, which impacts more than 176 million women worldwide. With these words, I request Dr. Abhishek Mangeshekar to commence his presentation, which will be followed by a question and answer session.
Thank you, Mr. Ranganathan. Dr. Mangeshekar, I have a request, and I think I will share with our viewers. We had received, to all our viewers, I would like to share that prior to our session, we received a large number of questions from all the students and many others, amounting to more than 24 questions already on WhatsApp, and also questions received from our implementing partner, CSER. So I have had requested Dr. Mangeshekar to incorporate the answers to these questions as part of his presentation, because many questions, since we are so unaware of this disease, are common. So in Dr. Mangeshekar's presentation, you will find that all your questions would have been answered. We will, of course, be taking other questions, which will come live as the session goes on. Dr. Mangeshekar, I think a couple of points that were highlighted is what is endometriosis all about? And what causes endometriosis? Is it hereditary? We don't know what is the relationship between endometriosis and PCOD, a condition far more talked about than endometriosis. Then, of course, the symptoms. Then, does it affect some women? Could it also affect in any way men? Radical questions, but we all need answers. We need guidance. So let's learn more about it. Dr. Mangeshekar, please do share your thoughts on this and tell us how to go about it.
Right. Thank you, Firstly, and good evening, and I want to thank VCAN and Mrs. Malkani for the invitation, and Mr. Ranganathan for such a warm introduction. I'm very honored to be here. This is a subject that is very dear to me. I only practice endometriosis primarily, and it is a very common problem, but has a lot of confusion and awareness about it. It is the most common gynecological diagnosis, but it is probably the least understood, the most misdiagnosed, and probably the most undertreated as well. So I have tried to address most of the questions in. We will also open up to questions at the end, and I hope I can cover everything in a good amount of time. I've not gotten too medical about it, so we can start the presentation as soon as possible. Yeah, can we start the
Can we have
presentation?
the presentation, please?
All right. Okay. So endometriosis is like I mentioned the most common disease. So we can go on to the next slide. Um, so this is a little pictorial I'm going to share, which is from an American artist. It's published on the Lily.com, and she does a lot of work with menstrual health and menstrual hygiene. So let's begin with a little story about an average young girl who gets her first period at around the age of 12. And many adolescents experience such severe cramps at this age where they are unable to attend school. And this is a very fragile point in their lives because their friends seem to be going through uh, the onset of their periods without any problem, maybe a little discomfort here. And these girls, particularly, are crippled in pain and they have to lay down in bed and they actually start wondering if there's actually something wrong with them. Next slide. So it became very apparent that obviously there is something wrong with her, and she lay up every month curled up on the bed with a hot water bag. The picture on the side shows a very common thing we see with patients, but again, this is not really picked up very often. These are burns that occur from using an electric blanket or a hot water bag, like chronically, to treat the pain. So parents are very flummoxed because they don't know what is wrong with their child. Next slide, please. And you see that the symptoms are a lot more exacerbated. While the common uh, symptom may be nausea, these are heightened where they become physically ill from the pain, or they start have episodes of blacking out, which because of the hyper stimulation of the nerves. And there is something known as the endobelly, which is caused by bloating, which it presents with bloating so that they look about 5 months pregnant. So it's called the endobelly. It's impossible to wear jeans at that time, and track pants are the only comfortable thing. Okay, next slide. So when as most 16-year-olds, and then she goes to her first OBGYN, when this is one of the biggest problems with endometriosis, where doctors and family members tend to dismiss young women with pain, and they said, oh, it's part of being a woman, it's toughen up, you can get married and have babies and this will get sorted out, or it's growing pains. And there are a lot of um, changes that occur during that. Next slide, please. So as you see, as the disease progresses, the symptoms progress as well. The pain scores increase. They end up for pain longer than their period. It can be before the period, it can be after the period, and it can lead to a sensitization of the intestinal system, which becomes leads to food allergies. If there are nerve involvement, they get shooting pains down the legs, as well as with to the lower back. So those are symptoms that are showing progression of disease. Next slide, please. So again, because they are given a plethora of over-the-counter pain medication or birth control pills or IVDs, or it's told they have PCO or IBS, you're hearing a different diagnosis from every doctor you visit, except for the one that actually works. So that is why we have these patients suffering through a whole series and probably close to a decade of misdiagnosis and misinformation that occurs, especially when they go meeting so many specialists and doctors. Next slide, please. So one of the questions is, what is endometriosis? It's when tissue similar to the lining of the uterus. So the lining of the uterus is known as the endometrium, that is shed every month as a period. Now, this is not exactly the same as the endometriosis. They bear structural similarities under a microscope, and this is very important to know on what causes endometriosis. So that can occur inside the body and grow, and it can grow anywhere in the body. It's not just related to the pelvic organs. It can grow in the chest, it can grow in the muscle, it can grow in the skin. Some women have had it grow in their gums and fingernails, and yes, it can also happen in men. So not just genetic men, women who have undergone a gender change, or even men with prostate cancer who receive estrogen therapy as part of that have developed endometriosis. So on to the next slide. So by the time she was 25, she's already been through a whole plethora of medications. And the thing about endometriosis is it doesn't kill, but it is a chronic disease that destroys quality of life. So even at best, if a woman is experiencing 3 days of pain out of a month, that is still 10% of her existence, which is in 10 years, if it takes 10 years to make a diagnosis, she's lost a year of her life. So and the problem with that is it's the leaky roof syndrome, which if you have a hole in the roof and it rains, you only have that problem while it's raining. And then if you have 29 days of sun after that, you forget about it until you have the leaky roof again. So we shouldn't underestimate this problem because it compounds. It's not just a simple addition. It's a geometric progression of problems and symptoms. Next slide, please. So then going on with our young girl now, she, as most of us do nowadays, Google their symptoms, and we know that Google can throw up a whole bunch of misinformation as well. But luckily, with endometriosis, next slide, there are many support groups online, such as this one, Nancy's Nook, which is the biggest one on Facebook, that has very well curated data, evidence-based, and it's a very good resource for patients to understand about endometriosis. And finally, this girl had some validation. On to the next slide, please. About her disease. And so it does affect 1 out of 10 women. We do suspect the numbers are a lot higher. This is what the women take who come forward. And on average, it does take 7.5 years to make a diagnosis. In her case, it took 14 years. So we always harp on this number of 1 in 10, which is that similar statistics to diabetes. Now, everyone who is probably listening has heard of diabetes, but I would say 1 in 10 people who are listening have heard of endometriosis. And I always jokingly say this, but there is an element of truth to this, that there is a deep misogyny among this, because if this disease affected men as much, I would guarantee you we would have a lot more action being done about endometriosis. So moving forward to the next slide. So, of course, we talk about surgery as the treatment. When you have disease, you have to remove the disease. That is, excision surgery is what is done. Now, there are many types of surgeries done for endometriosis. This is found to be the most effective, where you cut out the disease from the root. Now, this is a very difficult surgery to do, and it requires very specialized surgeons and training, which we will talk about later. Next slide. So she gets her surgery done, and the next slide. And she's a year out of surgery, and of course there's an improvement in quality of life. It does take time, and it's not just that the surgery is the first step. Of course, why we have a multidisciplinary center is because if someone is in pain, or imagine if you've sprained your leg or if you've got a cracked rib, you're constantly tensing the muscles around that. So the same thing happens with the pelvic floor. The pelvic floor is constantly tight, and that is why physiotherapy and pain specialists and nutrition play a huge role in the post-operative outcomes for our patients. So next slide, please. So of course, like we said, 1 in 10 is just not just a number. It is the ethos of the movement of endometriosis. So next slide. So now let's look at the definition of endometriosis. It's defined as the presence of tissue that resembles the lining of the uterus. And why I keep harping on it resembling the lining of the uterus and not being the same is because the long touted misconception of the theory that it was only caused by backward flow. If you can go to the next slide. Um, so what causes it was, if the first one, which was said retrograde menstruation is when period blood flows backwards and is implanted into the pelvis. This was the original belief that endometriosis would grow out of this. Now, this is been disproven a lot because it doesn't explain a lot of the types and variations of endometriosis and has not been very well reproducible as a theory. So we do not really, because the easiest way to stop retrograde menstruation would be to possibly clip the tubes if the woman was not interested in getting pregnant. So it doesn't really hold much water. There are many theories about, of course, there is a genetic origin, genetic factor to it. And there is also epigenetics, which are things that influence a young woman when she's coming into her age of puberty. Also, there is mulariosis and many theories, which also spread to why there is so much misunderstanding and lack of consensus among the medical community about endometriosis, and also what to do to treat it. And that is why there is so much headbutting about the whole issue. Next slide. So, like I said, for our immediate understanding and purposes, there's superficial endometriosis, which is small lesions of less than 5 millimeters, and deep endometriosis, which is the fibrotic endometriosis that we usually see it at imaging. The superficial may not be able to be seen on ultrasound or MRI unless it's very specialized and skilled. Next slide. So endometriosis is much more than just a painful period. It can present with random pain in the abdomen radiating to the back. It can go to the legs, the thighs, the groin. It can present as pain during intercourse. Some of these women who have long-standing distortion of the anatomy by endometriosis may present with infertility or subfertility. When you have vegetative symptoms, they may present with fatigue, bloating, nausea, vomiting, migraines, or headaches. They can have pain with ovulation. They can have pain with bowel movements or bleeding with bowel movements, pain while urinating, pain in the pelvic region, pain radiating to the lower back or legs, frequent urinations because of the hyperstimulation of the nerves. So if the bladder fills, it can cause discomfort, even heavy bleeding or irregular periods. And there is a big problem when it does reach the nerves. There's a very common, more common than we would like to acknowledge, of a phenomenon known as silent kidney loss, where the endometriosis goes and traps the ureter and causes the kidney to fail. It happens without any symptoms, and a lot of women with endometriosis may not have symptoms as well. Well, a small fraction may not have symptoms, but it depends how skilled the clinician is at looking for particular symptoms. We don't just stop at, do you have painful periods? We have to ask a whole bunch of questions about pain, if they experience any kind of pain or discomfort or heaviness. Next slide, please. So this was a very interesting study recently published by the BBC that was looked at a very large cohort of around 14,000 patients with endometriosis. And it showed that out of these 14,000, 84% said that they had a decrease in the quality of the work they put out. They were not able to achieve their work-related goals. Out of these, 1/5 said that they were temporarily disabled during some point of the month. 40% reported they were not able to achieve their career goals because of chronic absenteeism and underperformance. 3% reported total incapacitation, and 1% attempted suicide at some point of their lives. So out of 176 million women, if we extrapolate that, that is still a large number. That is 1.76 million women have tried to take their own lives because of chronic pain. So this is a standard course of a woman with endometriosis. And they reviewed this again, and they found that it still takes an average delay of 7 years. It depends on what country you're in. So from start of symptoms to first consultation till they see the specialist is a year. Then they take another 6 years till they actually have a diagnosis. Interestingly, a woman in the UK sued the NHS because it took her 10 years to make a diagnosis, and she was awarded £500,000 because they refused to take her up for a laparoscopy, and they constantly bounce her off from specialist to specialist. Coming to the pitfalls, the next slide. pitfalls of the endometriosis patient. And we like to talk about gaslighting. So what happens is, first, there is failure of support from the peer group. The friends will say, okay, you're a baby, you can't take the pain. And the family will say, get married, have children, all your pain will go away. And that happens in the medical community as well, when they're told, okay, it's part of being a woman, and that you're hypochondriac, their drug-seeking behavior, because they develop into chronic pain patients, and they obviously are on very strong painkillers already, and there is a degree of sensitization that happens. So they need to be on very high painkillers to even deal with the pain. And of course, coming back to misogyny, we talk about the gender pain gap and how women in pain are not taken as seriously as men with pain. I mean, if you see an emergency room, any man who walks in with testicular pain is immediately worked up with as much imaging as you can imagine and trying to rule out cancer, while a woman is probably given non-steroidal paracetamol and maybe just an ultrasound at best, which usually are negative unless the specialist knows what to look for. Next slide, please. So it's important how to diagnose endometriosis. The most important thing is to listen to the patient. So the disconnect in OBGY is that you cannot be seeing 20 or 30 or 100 patients in the OR and running in the OPD and running an endometriosis practice, because to talk to an endometriosis patient takes about 45 minutes, and to finish the examination of her completely and thoroughly takes another 45 minutes. So a consult with the patient of endometriosis for the first time should be, with me at least, takes an hour and a half to 2 hours. So I can't see more than 3 or 4 patients in the day. So if I'm running a practice where I'm looking after pregnant patients or general gynecology practice, it is impossible to do justice to these patients. So the need for specialist centers to deal with them. One has to go into the types of pain, a very detailed history, because they have a very long history. And when it comes to examining them, because they have such heightened pain sensation, we have to be as gentle as possible and understand that the patient needs to relax and they need to not feel rushed through the exam. Imaging is very important, and it does require very specialist training, because a lot of these patients will have negative ultrasounds and MRIs if done at generic centers. So it is important that our specialists are well trained to look for endometriosis and provide us with the specific reports that we need. Next slide. So when we talk about treatments, we have medical and surgical treatments. Unfortunately, medical treatments as of now have not shown to reduce disease. They are symptomatic control by suppressing female hormones, which means that they trick the body into thinking it's pregnant, which is a low estrogenic state, or treating the body into thinking it's menopause. But as soon as these hormones are taken away, the disease presents again with a vengeance. There's no evidence to show that one form of hormone is superior to the other. These are all that is available. And there's no evidence to show that they cure the disease. So surgery, of course, is very difficult, and there is a wide spectrum of surgery on who performs the surgery. So if we look at specialist surgery, it does improve quality of life. This was a study by De La Hera Lazaro, and the mean visual analog score of pain was 8.5, and of course improved post-surgery to 1.4. So pain is dramatically improved. And also when we talk about surgery, we have to talk about recurrence on the next slide. So a lot of people and a lot of specialists always quote recurrence rates. When we look at the broad literature, which shows everybody under the sun who does some treatment for endometriosis, it shows a variation from 6 to 67%, which doesn't give you any information. But when you focus that microscope on specialist centers, you look at much lower recurrence rates. So less than 3% or less than 10%, depending on what kind of endometriosis. And of course, next slide, please. This is acceptable recurrence rates to promulgate surgery. So I like to use this analogy a lot to just break it down into what an endometriosis patient feels like. So we talk about it with somebody has a splinter in their finger and they walk into the offices of various doctors. So the first doctor says, take these pills, that'll sort out your pain, which is what medical therapy for endometriosis does. The second one said, there's no splinter, it's all in your head, which is denial of disease. The third one says, I'm just going to burn off the top of the splinter, but we'll leave the rest of the splinter in and it will die off by itself, which is what ablation or burning the disease does. The fourth doctor, who is the radical doctor, will say, I'm going to remove the entire finger and possibly the hand, which is where you have the need, where they remove the uterus and the ovaries and hope the disease dies, which is not true, because the disease by definition is outside the uterus. And if you don't remove that, so for example, if you have appendicitis or you have endometriosis in the appendix, if you remove the uterus, you're still going to have endometriosis and appendicitis. So, and the fifth doctor, who is what I hope everyone strives to in the future, is what we need to remove the splinter in its entirety, including the root embedded in the flesh. Next slide, please. So, you can appreciate what endometriosis patients go through. And then, of course, there's a big, how would you say? There's a big fight in medical communities about who should operate, whether it's the gynecologist. In the gynecological community, should it be the laparoscopic surgeon, the fertility specialist, or should it be the gyne-oncologist? Because this is, by definition, much harder surgery to do than gyne-oncology. And no due disrespect to gyne-oncologists, I trained as a gyne-oncologist first, and they have no idea how to deal with endometriosis. It is much more difficult to do than cancer surgery. Urologists, of course, are required for some endometriosis, of course, and we do incorporate general surgeons in. And to say, would you go to any gynecologist would be akin to our next slide. So would you go to a general surgeon if you had to get operated on a brain tumor? The answer is, of course not. You would go to a specialist. So I give you the era of the laparoscopic pelvic surgeon on your next slide. So this is an endometriosis surgeon who has spent many, many years of training specifically in endometriosis at a high volume center with a multidisciplinary team in place. So by multidisciplinary team, I mean by, yes, it is led by our conductor, who is the laparoscopic endometriosis surgeon, and his viola and winds and brass section comprise of a fertility specialist, a urologist trained in laparoscopy, a laparoscopic colorectal surgeon, a pelvic floor physiotherapist, a pain specialist, a sex therapist, and a counselor for endometriosis. Next slide, please. So let's go through some of the frequently asked questions that I'm going to try and cover because we're running a little short on time. So is a hysterectomy a solution? Hysterectomy, this is something I put forth through because I said the guidelines of the American College of Obstetrics and Gynecology, the European guidelines, and our Indian guidelines mention that definitive treatment for endometriosis is hysterectomy with removal of the ovaries. But I beg to differ. For disease that exists outside the uterus, the indication to remove the uterus in absence of uterine pathology is unjustifiable, unwarranted, and must be re-examined for its utility as a therapy. So the next slide will say that patients, you can go forth, are automatically pushed into IVF by saying, okay, you have endometriosis, so they are labeled as IVF. So this is a common scenario where the doctor puts forth the Sophie's choice, which says, are you interested in relieving pain or are you interested in getting pregnant? So the patient at this stage will say, okay, I can deal with the pain, but I will try to get pregnant. And they are subjected to repeated IVF cycles and forever deemed as IVF. But the question negates the fact that both goals can be achieved simultaneously by just removing the disease. There's enough evidence to support, and the biggest is by a colleague of mine in Bordeaux, Professor Roman, who shows that excision improves pain and also improves pregnancy rates. And most of these women do conceive naturally. And a few of those who don't do require IVF or ART after trying to conceive naturally. So next slide. So this is his study, if anybody wants to go and look at that. So let's look at the next slide as to why medical therapy fails. And if we look at medications for endometriosis, most of them aim to suppress estrogen, which is tricking the body into thinking it's in a state of pseudo-menopause or pseudo-pregnancy. and they suppress estrogen and the estrogen related flare ups. But endometriosis, one, makes its own estrogen, and two, it is a hormone dependent disease and not only estrogen dependent. So it does continue to grow in the absence of estrogen because it does produce its own hormones. Then the next slide is whether pregnancy cures endometriosis. So this is a lot. Every woman I've met has been told to get pregnant at some point or the other to treat the endometriosis, but this is a big no-no. Pregnancy does not cure endometriosis. It was from a very falsified study in the 80s where somebody noticed that a chocolate cyst ruptured and they couldn't see it at the time of cesarean section. So that leap of faith transpolated into somebody saying that pregnancy cures endometriosis. And hopefully this is disappearing. But the reality is, like, it doesn't, it still is quite pervasive and prevalent in medical culture. Next slide, please. So why medicine has failed women is that there were a lot of wrong definitions and causes about endometriosis talked in medical school. In undergrad, there's a paragraph dedicated to endometriosis. In post-graduation in obstetrics and gynecology, it's a chapter. I can safely say that no resident gynecologist is trained or equipped to handle endometriosis surgically. And we know this from seeing that the time from diagnosis to the onset of symptoms is anywhere between 7 to 12 years. OBGYs are taught to not misdiagnose, but to treat everything else except endometriosis by a diagnosis of exclusion, which is wrong. We could do a lot better by just assuming every woman with pelvic pain has endometriosis and working backwards from there. We'll have a lot more or a lot less misdiagnosis and a lot more diagnosis if we approached endometriosis with that train of thought. So we also have no training curriculum, at least in some medical colleges, for a strong laparoscopy program, and let alone for endometriosis surgery. So we need a big change at the grassroots level of how we train our medical students. And again, finally, women are just told to get pregnant. Next slide. So about food sensitivities, yes, there is a very big link between endometriosis and food sensitivities. Next slide. Because a lot of them, one, I said there is a hyperstimulation. So there is neurogenesis. So the nerve fibers are recruited because of the pain. So also for the gastrointestinal tract, so there's, like we said, we have bloating. So if you imagine if someone like me or someone who doesn't have endometriosis drinks a cup of coffee or has gluten, yes, we might have a little bit of indigestion, but someone with endometriosis has a very hypersensitive response. So their intestines will completely bloat to the insult of having coffee or gluten, for that matter, especially now with animal protein which is injected with antibiotics, or even animals raised in inhumane conditions. The stress hormones in that meat can also trigger the cytokines release, can also trigger an inflammatory reaction in the human digestive system. So the whole gut mobility and motility is a very needed study topic. So one of the other questions I wanted to address was warning sign in adolescent endometriosis. The next slide, please. So teenage endometriosis is very difficult to pick up, and doctors are very hesitant to operate upon them. And parents are very hesitant to get their daughters operated upon. So what you should look for is when they have chronic absenteeism from schools, coursework, or sports or social activities. One should not be dismissive of their pain or if they have discomfort during the period. Inability to concentrate on schoolwork or activities is going to lead to a drop in performance, as we've seen before. And food sensitivities, these girls may be depressed because they don't know why they're feeling such high amounts of pain. They obviously, because you're constantly on fight or flight response, they're going to be very anxious, and the come down from that anxiety leads to chronic fatigue. So next slide. What can we do as a society, not just as a medical society, but everyone who's listening in? We understand that pain is not normal. Pain is a symptom of an underlying problem. So don't treat the pain, we treat what the cause is. So one must look into a probing history regarding pain, because patients are conditioned to not talk about menstrual health. This is a very taboo subject. and it's brushed under, well, a lot of rugs for some reason. We need to initiate and incorporate awareness programs within the community to make young women conditioned and comfortable come out and speak up for themselves and not trivialize their pain. So 3 years ago, next slide, we launched the Indian Center for Endometriosis. And the aim was, of course, the multidisciplinary approach to endometriosis, but we also wanted to come up with the social approach to endometriosis to kind of help create awareness. Next slide. And to create partnerships between patient and associations, awareness groups, and endometriosis centers. So primary care physicians at the grassroots level should be able to diagnose and direct patients to endometriosis centers. I mentioned to Mr. Ranganathan earlier that Australia is the first country that has established a clinical pathway to establish this, and that is the way forward, and hopefully we should be able to achieve that in our country too one day. So in the meantime, the social aspect of ICE is to be a knowledge-based resource for patients and physicians to identify specialty centers across the country and to provide resources for patients and for physicians as well. We must remember to manage the patient and not just the symptoms, because incomplete and inadequate surgical therapies by inexperienced surgeons leads to frustration. Patients who go through revolving door surgeries and unnecessary hysterectomies and unnecessary IVF procedures and unnecessary castration at a very early age. Next slide, please. So that is why ICE created. Can we go into the next slide? And our goals were to create awareness, to educate women and physicians across the board, and to kind of, from the surgical point, is we have to tailor our approach to each patient. And because everybody's goals of treatment are different, and you can't just say a blanket therapy is going to work, or I'm just going to do this surgery for all my patients. And it starts by listening to our patients and affording whatever resources we have available to our patients to be able to set up, and also to be able to train and educate physicians as well. So with my last slide, I'm going to thank you for your time. And these are available resources that you can get in touch with ICE on Facebook, Instagram, Twitter, email, YouTube, and WhatsApp. And thank you for your listening. And I'll take questions now if we're willing.
Thank you so much, Dr. Mangeshikar. I am absolutely, I was fascinated to see the lack of knowledge of this highly, how should I say, unknown condition. And, one of the common things that I have heard, and in fact, from our implementing partner, CSER also, an organization which works primarily with children and young adolescents and the parents, that for menstrual hygiene, for example, we talked about menstruation. It's a taboo subject, no doubt, and that taboo must be eradicated completely. How we are going to do it? By speaking out. All of us need to talk about it. Now,
Yes.
giving a hot water bottle, if you have pain can't be natural, but that is what is commonly known. So,
Yes.
this is just the first step that we have taken. And on behalf of VCAN, I can say this, that we are extremely, keen to take forward the awareness of endometriosis coupled with all the other issues that are related to endometriosis, which obviously menstruation is one big chunk of it. It would be nice to know if you feel that there is any possibility, considering the gender disparity as came through from what you were saying. Do men ever end up with any symptom of endometriosis?
Yes,
Any
that's a good question, but it is mostly restricted to women. There are a few cases related to men. I said after prostate cancer, if they've had surgery and they're given high doses of estrogen to suppress the cancer, if they've had endometriosis, that is triggered to grow under the influence of those high doses of estrogen. So those cases have reported, but they are very few in the literature. I personally haven't seen any, but I've read a few reported in.
Well, if there are some, then so be it. But we need to look at it. And obviously, you also said that genetics plays a role in endometriosis, does it? So is it hereditary? Because I know for cancer,
Yeah.
often the history of the parents are taken. You know,
Mhm.
when we are diagnosing, or you're talking about even a normal gynecological visit for a
Yes.
woman.
Yes, there is a genetic link that has been identified, and there's a lot more ongoing research into it, into what specifically what kind of genes. But what we've noticed is that a lot of immediate relatives, like mothers, daughters, aunts, and everyone shares that. But what's interesting is also that, like I said, there's an epigenetic variation. So identical twin girls may not have the same presentations of endometriosis. They may have endometriosis presenting in different compartments of the body. Even at different stages. We're not going to really talk about stages because that's a very whole long academic topic as well. But so there is, yes, there is a genetic component, but there are also a lot of other factors that probably entail how the disease progresses and presents. So we do need to, there's a lot of ongoing research in that.
So when you talk about immunity, uh, what are the factors which trigger the
I'm sorry, can
genes?
you repeat?
What are the kind of, see, you are
Yes.
talking about epigenetics. Now, we would like to know what are the factors which triggers the genetic system so that the disease manifests itself, and what preventive measures can be
Okay.
taken.
So most of the um, predisposing factors that we have in literature is a little bit confounding, and I don't necessarily believe it so much. But of course, when we look at epigenetics, it will be more hormonal milieu. If there is a hormonal imbalance, which is probably why we see such a big cross relation between PCOS and endometriosis, or maybe adenomyosis and endometriosis, because of a little bit of imbalance in the hormones when puberty kicks in. So that is usually when estrogen becomes dominant in a young girl's life, is when they would present primarily. Um, that is when the endometriosis would announce itself, so to speak. Um, then the
You have
other are very, I don't really like a lot of the predisposing factors. You can find in some texts that they said endometriosis is primarily seen in the white race. It affects Caucasian women more. But this is absolutely untrue. And I think the data is very biased. So I don't really, even in one of my textbooks, if I go, if I remember correctly, it said one of the quotes on there were fibroids are the fruits of virtue, and endometriosis is the fruit of sin. As in, you would see fibroids in women who have never got pregnant, whereas you would see endometriosis in women who were promiscuous or sexually active, which is wrong, because they were constantly misdiagnosing that as pelvic inflammatory disease, and pelvic inflammatory disease is rare, but they were pelvic inflammatory disease is a high transmission rate of sexual transmission. So I think most of the literature needs a serious overhaul and update, and it really makes me shake my head when I read some of the stuff. So I don't really subscribe to them.
I think we already have one Facebook
Yeah.
question which is
Okay.
on the screen.
Yeah.
You maybe should take that up, and then I was going to add
Okay.
something more.
Yeah.
So, would you like to answer?
Okay. So the staging of endometriosis. So the most common staging is from the American Society of Reproductive Medicine, which divides it into stage 1, 2, 3, and 4. Now the staging is only done surgically when we put a laparoscope in and look at what kind of disease there is, what the involvement of the ovaries are, if the area behind the uterus, between the uterus and the rectum, is obliterated, so to speak. There's a space there that should be open, but if it's obliterated, so usually that divides the stages into 1, 2, 3, 4. Now the stages are useless because they don't tell you anything about how difficult your surgery is going to be. It doesn't tell you anything about what kind of symptoms your patient is going to have, and it doesn't really give you an idea about fertility outcomes either. So, for example, a woman with endometriosis in the parametrium and the uterosacral will be termed as stage 2 disease, which is a very difficult surgery to do, as opposed to someone with an early stage 4, which will take someone about an hour and a half to do, while the stage 2 surgery is much more difficult and will take 3 hours to do. So I don't really like the staging systems. There are many other staging systems with regards to fertility. There's a very good one by Professor Keckstein, which is the Enzian staging system, which looks at disease in different compartments. It's a little difficult to understand in the beginning, but once it's adapted in by an endometriosis center, it's very good. But on the whole, for patients to understand what staging is, it's not really necessary, except to just kind of explain to them where their disease is and what procedures need to be done.
Oh, thank you, Dr. Mangeshkar. At this point, I would like to share with our viewers that whilst this session is going on, Dr. Mangeshkar will be answering questions going forward directly. So we request our viewers to please join our TogetherVCAN group on Facebook, where Dr. Mangeshkar will take questions and answer them. Because with this, there is so much to talk about. And I mean, we can't do it in one session. And it is so much better if you directly ask the questions, and Dr. Mangeshkar will spend time to answer all viewers. So having said that, let us go more to our other questions. Here you are.
Okay.
All yours.
Yeah, I was so Miss Janvi Chatalia would like to know if endometriosis is a recognized autoimmune condition and can be worked on by focusing on gut health for pain relief or symptom control. Also, is PCOD required as an autoimmune condition as per recent studies? So that's a very interesting question. So an autoimmune condition is kind of where the body attacks itself. It produces antibodies against itself. So that was one of the theories for endometriosis. And like I said, we don't, in all honesty, we don't know what causes endometriosis. There are many theories. And this would be one of them, that the body does produce antibodies, and that it is an autoimmune reaction to endometriosis tissue that occurs in the body. So I don't know how well we can answer that question without much more research into it, but yes, it is a theory. So can we put the question back up? There were a couple of parts to it.
No, the past.
The previous question?
The previous,
yeah.
Yes.
So is PCOD recognized as an autoimmune condition? And yes, coming to gut health and for pain relief or symptom control, yes, there is a lot of study going into the microbiome of the gut now. And yes, it does work a lot for endometriosis patients. I do recommend a lot of my patients get on working with a nutritionist. We have a very good nutritionist who's part of our team who deals with endometriosis patients, and reports have been good because they do follow up with the patients and, basically reducing inflammatory foods into the digestive system to reduce the insult to the digestive system while the body is in healing. Yeah, so that does work. Okay. There was the next question. Okay. So what is the recommendation for adolescent girls who complain about period pain? So you should take them to see a specialist. Of course, we would recommend that if there is pain is subjective, so it's difficult to gauge the kind of pain. So that would best be done by a specialist center if there's any doubt. So what kind of pain, what is the onset of pain, what are the exacerbating factors, what makes it worse, what makes it better, what is the degree of incapacitation, does the pain make her... So for yourself to answer the question at home is, does it interfere with quality of life? So what that means is it stopping her from going to school? Is it stopping her from going to college? Is it stopping her from going to work? Is it stopping her from social activities? Is it stopping her from concentrating on work product? If an answer of any of those questions is yes, then she does need to see a specialist.
Okay.
In regular annual medical checkup, can this disease be detected? So that's interesting because yes, it can be accidentally detected in cases of um, asymptomatic patients, and sometimes it gets diagnosed accidentally when the patient presents in a fertility setting when she's trying to get pregnant. So that is the accidental diagnosis, but I don't think it's necessary to get an annual checkup specifically for endometriosis in the absence of symptoms. One, because uh, the diagnosis is very specialized. It is not easy to make a diagnosis also via ultrasound or MRI, or even just you can't put a laparoscope in without an indication if the patient doesn't have pain or is presenting with any symptoms. So we cannot uh, diagnose that as a routine examination, for example, like a pap smear, where you do yearly screening for cervical cancer, for example. So no, I don't think an annual checkup is this. But if a patient has a diagnosis, then yes, of course, she is followed up. So post-operatively, patients are followed up 3 monthly, 6 monthly, 1 yearly, 2 yearly, 5 yearly, and so on and so forth.
Okay. There was an SMS. Okay, another one. I must say the gentlemen are asking questions, and I'm delighted.
That's good. What will be the approximate cost to set up a special center? That's a
Ah,
very tough question.
very, very apt question.
Yes. So, of course, the infrastructure is tremendously expensive because you need, so the surgery, we need a good laparoscopy setup. We need a minimally invasive setup for a theater. And the imaging is, of course, expensive, especially MRIs and probably ultrasounds, depending on what kind of resources you're working with. And of course, the cost of training the specialists, it's not cheap because, of course, we need international level training and we need to set up training centers and we need specialists to come and donate their time to set up training centers. So I cannot even ballpark a figure off the top of my head. So that is for people with MBAs and not MDs to figure out. We leave that to them. But yes, that is a good question. But of course, the goal of ICE is we need to bring down the cost to make the treatments available for women, for patients rather, from all walks of life. And with that is the good part of being in Mumbai practice is that we have access to a lot of hospitals that allow us to be flexible with budgets. And also we have tie-ups with a lot of centers that anonymously donate to help underprivileged patients. And
Okay.
I'm proud to be associated with those groups. So yes, we do want to make it as patient friendly as possible.
There are quite a few things that we need to move with, from what I gather.
Yes,
Okay,
absolutely.
here you are.
Yeah,
Uh,
so we have with a history of one stage. So I'm assuming this is a history of stage one laparoscopic surgery for endometriosis. How frequently should I get myself checked for reoccurrence?
ah,
So, my question would be: is the staging was done at laparoscopy, and uh, I always ask for what, assuming what kind of surgery was done. So whether the disease was removed or rather simply it was just burnt and the surgery was done in 30 seconds. And if she has recurrence of symptoms or if she has any follow-up symptoms or any kind of recurrence, and then if she does need to follow up, yes. So I would recommend following up 1 yearly with a good ultrasound or an MRI, depending on what kind of symptoms you present with.
okay.
So Mrs. Angadi asked if a pap smear helps. So no, a pap smear does not help with endometriosis, but as a doctor, I would say a pap smear is very important for women to get done yearly, and it is very useful in preventing cervical cancer.
And that age would be, when do you recommend pap smears to start?
So the age of first sexual activity is
Okay.
when
So
a
there
pap
is no
smear should be done.
biological age that you wish to.
No.
Okay. Ah,
Yes. So how many ICE centers? So we are one center, but we have attachments in various hospitals that I'm associated with, uh, and always looking to collaborate with other centers across India, and get surgeons trained and vetted. So there are surgeon vetting programs coming in. One of them I'd like to mention is called I Care Better, which is an American program, and it is very important because it's not just now in the age of the internet, anybody can get online and say, I'm an endometriosis surgeon, and probably not have any idea about what to do for endometriosis. So these centers are basically what we call the highest evidence of medicine, which is double-blinded peer review, what you would consider doing for a clinical trial. So the applicant will send in anonymous surgical videos, and the people who are reviewing are already experts in the endometriosis field, will be blinded to the identity of the surgeon, and they will critically review and evaluate videos to see whether the surgical approach is appropriate, whether um, the surgery in itself is effective, and whether all endometriosis is identified and removed. And once you get that done, then you get the pass or fail according to whether you need mentoring and what kind of endometriosis surgery you're qualified to perform. So I think those centers are very important, or that vetting process is very important in identifying surgeons of excellence and coming up with centers of excellence as well.
well, Dr. Mangashikar, I must say that considering that our implementing partner CSCR will be also joining in to take this forward, you may guide us as to how we can bring forth the awareness and what role CSCR and VCAN can play with ICE going forward. So
Absolutely.
that's
We're very proud to be associated, and we'll do everything. All our resources are at your disposal and that of
okay.
CSCR.
So I think post your session, we will have a meeting with Mr. Wadhwani of CSCR, myself and yourself, and work this out. In the meantime, as I mentioned earlier to our viewers, and I reiterate once again, that to please join the Together We Can group. I would like the banner for the Together We Can group to be displayed here, that all you need to do is to ask, and we will approve immediately, so that viewers can immediately and directly ask you questions and keep the dialogue open, the conversation going on the subject, because that is the first step, I feel, in community awareness. Unless we talk about it, the subject will not really be known, and it will remain more on the clinical side and not as part of awareness as we are looking to achieve. We have crossed our 1 hour time, but I know questions have come. So we will have to, at some point, close the session now in another few minutes. There was an SMS question which could be please put up, because this is something also asked multiple times to me otherwise. So what would you say to this?
Yes, that's a very, very good question, and it should be addressed. And I'm very grateful this question has come through. So, can
And it comes
endometriosis?
from a young man, I must
Oh,
say.
that's very good.
Yes.
So, can
Yes.
endometriosis occur after menopause? And the answer is an emphatic yes. It can. I have a very personal experience with a lot of patients that have endometriosis left behind after, whether it's natural menopause or surgical menopause. Surgical menopause is when you surgically remove the uterus and the ovaries, or rather surgically remove the ovaries, but usually the uterus is removed as well. So like I said before, the endometriosis will produce its own hormones, and it's not that hormone levels drop from 100 to 0 immediately after menopause kicks in. They still do persist, obviously not at functional levels, but at much lower levels till they decline and taper off at maybe the age of 60, 65. So yes, endometriosis can progress and can be symptomatic and problematic after the age of menopause. There was a very interesting case that one colleague had just put up, and it showed a 76-year-old woman who had a bowel resection of a huge amount of intestine, and she was just treated as an IBS patient with chronic constipation for years, and it was a toxic megacolon caused by a block of the intestine caused by endometriosis, which is it's
Wow.
just neglect at that stage. I mean, it's terrible. I mean, for her now, she has to live with a colostomy for the rest of her life, which is horrible.
Oh, that is really sad. Ah,
Yeah. Okay. So is CA125? So CA125 is cancer antigen 125. It is one of the biomarkers that was thought to be that is sensitive for endometriosis, but actually it is very. It's not a great marker because it has. It's not very sensitive. It's not very specific for endometriosis. So any inflammation can cause CA125 to be raised, and it doesn't mean that usually a lot of patients will say that, oh, I've got a raised CA125 level. And when you Google it, the first thing it says, ovarian cancer. So patients will have an endometriotic cyst, they will have a raised CA125 level, and they think they have ovarian cancer, where, okay, the endometriosis will cause a raise in CA125 levels, but obviously not to the levels of ovarian cancer. There will be a mild elevation, which is seen in inflammatory conditions such as fibroids, adenomyosis, and endometriosis. So CA125 is not routinely done for endometriosis. It's not prognostic of whether the disease is treated or not. So CA125 is absolutely not very helpful for endometriosis.
very interesting. And I'm more convinced that your interaction directly on the TogetherVCAN group will probably elicit many more questions, which really requires to be talked about. Because when it's in a public forum, and we will publish your answers naturally. I think we will have to end the session here because we have crossed our time. But as I said, there is so much to do on this subject that we can continue for another couple of hours. But I think we will close the session now. But before we do that, there are two things that I would like to bring forth. To do all the work that we do or that we propose to do going forward, we need support from all our viewers. And without the financial support, it makes it very difficult for a public trust to actually bring forth the sort of work that we bring to you. So we appeal once again for your generous contribution, which will be used for the objects of the trust, but primarily we will focus a lot towards health and well-being. That's what we find today is the first point where we need to address all our resources. So this is a public trust, so you will be eligible for the tax deduction at source. I would also request our viewers to please subscribe and like the YouTube channel, because as we bring more sessions which will be towards health also going forward, notifications will come to you. At a happy moment now, normally if we were having our normal social sanchar in person, we would be handing over our memento to you, Dr. Mangeshikar, for being with us. But on behalf of our trustees of VCAN, may I present our virtual memento to you for being with us. The actual memento, of course, will be delivered to your table. I really must thank you for sparing your time, and most importantly, for being with us going forward as a tie-up with ICE and VCAN to bring awareness on this issue, which is the condition where so many suffer without knowing why and how to treat it. Endometriosis needs to be talked about. The taboo around menstruation need to be spoken about, and actual knowledge be brought forward. and wherever we can help, we are there. So with that, I once again thank Indian Center for Endometriosis for being with us for this particular social sanchar and being
Thank
with us in time to come, in the days to come. Uh, the students, I'm delighted that even though their exams are on, they have been so motivated to find out. I'm sure that many have been suffering and they didn't know what it was. So they felt the need. And quite honestly, so many said that we knew nothing about it. So that just tells us that what lack of understanding about this condition and disease. I thank our implementing partner, CSCR. We have a lot of work to do in going in the days to come, and our whole team. And once again, thank you so much, Dr. Mangeshikar, for being with us this evening. Thank you,
No,
viewers, and do join us again when we have our sessions.
it's my
Thank you.
pleasure. Thank you.